Good afternoon, everyone, and welcome to session 2, labeled Balancing Cost and Quality in Pediatric Care, Challenges and Opportunities. I'm delighted to be chairing this session. My name is Haroon Saloojee, and I'm a pediatrician based at Wits University. So in this session, we will be exploring innovative strategies to deliver high-quality pediatric and child care while managing the costs effectively. And so our session will begin with insights into what constitutes a good buy in newborn and child health interventions in South Africa. We'll follow it with discussions on innovative and cost-effective approaches to pediatric childcare globally. And then we'll address how to manage limited resources without compromising quality. And then we're going to have a short 10-minute panel discussion after this before we move on to our second segment. And so in the second part of our session, we're going to shift the focus onto the role of technology and artificial intelligence in optimizing healthcare. And we'll hear from 2 national and international experts on how we could best leverage these tools to provide cost-effective care, followed again by a short panel discussion. So I think we've got an exciting lineup of speakers and panel discussions ahead. Let's dive in and explore these critical topics together. And once again, thank you for joining us. So let's get on and load the first presentation. Our first speaker is myself, me. I'm a founding member of the Child Health Priorities Association and also its current treasurer. So I do spend a lot of time thinking about money and ensuring that the Priorities Association does not waste your and our scarce resources. So it's not inappropriate that I start by discussing what are good health buys. So let me go ahead and share my presentation. Thank you. All right, so tomorrow is Black Friday, and I think everyone is hoping to get a good buy. And the question is, what's a good buy? Clearly, it's probably something you do need rather than just want. Hopefully, it's of a good quality, and hopefully, it's something that will serve its purpose very well. And of course, I think an important consideration is you want to get a bargain. I think some of the same considerations apply in healthcare as well. And so as we discuss the issue of quality healthcare and effective healthcare, we have to talk about resources and making sure that we use our resources effectively. And so today, this my session is really a primer, a quick ABC of what are some of those economic considerations. And then I'm going to present some ideas of what I think would be very good buys considering neonatal and child health. So we'll do that in the next 14 minutes. So what is a good intervention? And I've just gone through some of the things at a personal level. What's going to decide what I do tomorrow is that whatever we choose should have these health benefits. And the words we often use is cost effective, but I'll talk about that just now. We talk about health burdens. And so whatever you're taking on must reduce these health burdens. It clearly has to be feasible and sustainable. And ideally, we talk about equity. So whatever we do should be trying to minimize the disparity between rich and poor. Now, there are frameworks for doing this. And I'm going to spend a little bit of time, the first 5 minutes, going through some of these issues. But there's 4 key points that I'm going to make. One is that we have to consider what's the burden of the disease. We want to obviously target in our interventions things that matter, that are important. The economics of it is quite important. And so I'm going to be talking about various economic measures that determine, and that's the thrust of my presentation. I won't talk too much about scalability and sustainability, but clearly anything we take on, we want to be able to ensure it can continue for the next 5, 10, 15 years. And then finally, it has to align to our national policies. And we know our current policy is driven by the future needs of NHI, but the underlying principle of universal health coverage. Okay, so let's look first at what do you think about burden of disease? And I think most times when we look at graphs, you would usually get a pie diagram that gives you these are the causes of mortality. But this is becoming more popular. This is called a tree map because like a tree, it's got different branches and it tries to segment key features. So what do we see here? We see here the global burden of disease 2015 based on DALIs, which I'm going to talk about in a second. But really what this shows is what are the major burdens of disease globally, considering adults, children, everybody. And I think what you see there is that things like stroke and ischemic heart disease are very important. But there's quite a big of this fringish pink element, which is where our child health sits, including some at the bottom, more infectious elements, and then right at the bottom, the green suggesting injury, which affects children. Okay, so that's the global burden. But if one looks more specifically at, and you can see the neonatal component is quite a big component, but if one looks more specifically, uh, it talks about burden of disease. And one of the measures we do that is called DALYs, disability adjusted life years. And how that's different from simply causes of death is it brings disability in as well. So saying, what's the contribution not only of people dying too early, but what about living lives and years of life lost due to disability? So that's all I'm going to say about DALYs. We're not going to make it too complicated. But if one looks then in South African data, and unfortunately this data is somewhat old because we don't have more recent data. So this is at least now 2015, 9 years old. But if one look at 2015, it shouldn't surprise us that if we look at the burden of disease, both mortality and disability, HIV was the dominant condition there. And I would presume it still is an important factor, even though we've had lots of progress since 2015. Okay, but looking then much more specifically, this is just everything in South Africa. And again, you can see the ischemic heart disease and stroke. What if we then look at our area of interest, which is children under the age of 5? Again, this would be well known to most people in this audience. We've got that neonatal component with preterm and the neonatal encephalopathy, sepsis, and other. We've got the infectious component, mostly of diarrhea and pneumonia. We've got a bit of congenital HIV sitting there. So this is what the burden of disease. So any intervention we choose would have to target these as our primary determinants of what we want to approach. So that's a little bit about burden of disease. Now, a little bit about cost effectiveness. And again, I'm going to try and do in 3 minutes a whole session on how does one decide what are the economics of making healthcare decisions. And so you'll see, I mean, most of us have heard the word cost effectiveness, but in fact, it's a little bit more sophisticated than that. And the kind of analysis you do might be a cost benefit analysis. It might be a cost effectiveness or something like a cost utility analysis. Now, again, I don't intend going through all of these in great detail, but just to make the point that cost benefit really is looking at for the amount of money you spent, what are the benefits you're obtaining? And that's usually saying, say, what would be your reduction in mortality? If you spend this amount of money, how much reduction in mortality? 10% would get. Is that better than another intervention where you might get 15% change in mortality? Cost effectiveness talks about health units. So we talk about, for example, years of life saved. I'm going to show you a slide on that. And cost utility starts using words like DALYs and QALYs. Now, I've told you DALYs is a combination of death, the burden from death and disability. QALY is the change in the quality of life from whatever disease you've got. So it's bringing in societal preferences. If this is all sounding too much, not a problem. It's not a key part of the thing. But just to give you some examples quickly, so cost would be, we all know, how much does it cost? Obviously, cost alone is never, because a cheap intervention could be useless and a very expensive intervention could be highly effective. So cost alone is never important, but we need to always consider cost. And so here's an example about what it costs for preterm births in America. So they spend something like $26 billion on preterms, which is twice the health budget in South Africa. And every preterm baby on average costs $51,000, which is R1,000,000. So that's what a preterm costs. And where does that money go to? Well, on the side left, you see a pie diagram, and about 2/3 go to medical care. But when thinking about costs, there's other things as well. In this case, for preterms, what's the cost of maternal delivery, the early intervention services the baby might need, special education services, and even losses to the parents because they're now looking after the little one instead of working. Okay, so that's a little bit about that. Then we talk about effectiveness and how does one measure effectiveness? And there are different ways to do that, but certainly one we use in the clinical sphere is the concept of numbers needed to treat. And all that means is how many people do you need to treat for one person to benefit? And we often think if you take a medicine, you give it to one person benefits. That's not true. Most medicines, if you give it to 3 or 4 people and if one benefits, it's actually a very effective drug. And so kind of example I've given you is we often give phototherapy to prevent children getting kernicterus or high bilirubin levels and prevent them needing an exchange transfusion. Now the question is, how many babies do you have to give phototherapy to prevent one baby not needing an exchange transfusion. And you might be surprised at the number. The number is like 300. You have to give 300 babies phototherapy to prevent one exchange. Now, is that then worthwhile? And I think most of us will agree it is worthwhile. Why? Simply because it's such a devastating effect to have kernicterus that I don't mind giving 300 babies phototherapy just to prevent that one episode. Okay, and so then there's whole issues around cost effectiveness, and the way we measure it might be something like the concept of lives saved. If you use a particular intervention, how many lives will you save? And it's very difficult to see the slide I've given you. It's very small, but it's taking some maternal and newborn intervention and saying, if you use neonatal resuscitation at full coverage, how many lives might you save? And you see it says here it's around 700. And then what about another intervention? Say, for example, antenatal corticosteroids. And if you use that to full coverage, you might save 2,000 lives. So it gives you a sense of one way of measuring what's the impact of your intervention. Okay, and this table puts up another way of showing this, where if I asked you what's the intervention that will save most lives for maternal and newborn care, I'm not sure you would come up with the answer that it's antenatal corticosteroids, which probably will save the most lives. And there's a list of some of the other stuff. This is not just maternal and newborn. This is newborn and child health interventions. So you have a kind of a sense of, is one intervention likely to, at a level of life saved, be more effective than another? And you can see there are things here like hand washing with soap, which is a very effective intervention. It will still save a lot of lives. Okay, and so how does one put all of this together? Well, let's look at two examples. There's neonatal resuscitation and breastfeeding promotion. If I asked you, which one of those do you think will give you the best at the cost for the number of lives saved will be the most effective? And I guess most people in this room would say breastfeeding, but let's look at it. I'm going to do this very quickly because of the time limits. Okay, so neonatal resuscitation can save, if at full coverage, 134 lives. Breastfeeding will cover about 427 lives. What will be the cost of delivering this program, whether it's breastfeeding promotion or neonatal resuscitation? Well, you can see neonatal resuscitation will be about $20,000, and breastfeeding would be 10 times that, $227,000. So if you look at the life years gain, which basically is the lives time you can expect every one of these people in South Africa to be staying about 60 years, you'll get about 8,000 years compared to the 25,000 years. But here's the bottom line. For neonatal resuscitation, the cost per life year gain, you take that cost by the life years gain, it's about $3 versus breastfeeding, which is closer to $9,000. And this might come to you as a surprise. So from a cost effectiveness perspective, neonatal resuscitation is much, much more cost effective than breastfeeding promotion. And that is the kind of numbers you get a sense of, is what is the cost per life year gain? And you get a kind of a sense of which intervention may be a more or less if cost effective than the other. Okay, and then finally there's cost utility analysis, which talks about DALIs. I'm not going to do that because I've just realized that I'm running out of time. But all that does is it says how rich is your country, and depending on how rich your country is, you may decide which interventions you want to use or not. So this is the key message here is we use GDP per capita, we take the whole country's wealth and divide the number of people. In South Africa, you can see our GDP per capita is around $6,000 per year. It used to be more. Okay, and what we then do, and I'm doing this quickly, is then there's a whole list of interventions that you may choose. And at the bottom here, you see it's the cost effectiveness ratio. So if an intervention is very cost effective, it will have a low cost per disability adjusted life year. Like in this case, albendazole is only about $5, while stroke care might be a little bit more, and unwanted pregnancies cost more. But the cheaper it is in terms of dollars per DALI, the more likely that a poor country can afford it. And so that's the thinking behind how we choose. Each of these interventions has got a cost per DALI. We've got a number of interventions in South Africa existing, which if you look at the cost per DALI, and the key message with what's an affordable cost for a country is you look at their GDP, which in South Africa is 6,000, and if it's below that per DALI, if it costs you less than 6,000 per DALI, then you basically have got a highly cost-effective intervention. And a lot of these programs, like neonatal resuscitation, have got $20, $30, which is much below $6,000, and so are very, in terms of cost utility, are very affordable. Okay, so these are the kind of things that we do have, and examples of existing interventions, which is a good case for making it. But where I want to go to in the last few minutes I've got is the additional things we're going to have to think about. And I've got about 3 minutes to tell you the 10 things I would tell Minister Haroon Saloojee, that why aren't we spending more? These are not necessarily new buys, they're existing buys, but what would be some of the things I'd be arguing for? And I'm going to do this in 3 minutes. 10 buys in 3 minutes. I'm going on a buying spree. The early childhood development we all know about, it's not mainly a health intervention. We know that it's more about educational benefits, and social outcomes are much better. But again, if you look at how much it costs, it basically would cost us about 2,000 to 3,000 annually. But the real value of early childhood development is that return on investment is incredibly high. If you put that 2,000 or 3,000 rand per child in South Africa, you're going to get returns of 4 and 13. So we've got an existing program. I don't think we've done very well in getting it up to scale. The next program that we've spent a lot of time on, every conference we talk about since primary healthcare re-engineering in 2012 is community health workers. The evidence is very clear in terms of its cost benefits. It's great. It's relatively low cost per dali, $10 to $200, and yet we haven't maximized it like many other countries. So this is an area where I think it needs more investment, and there's lots of reasons why we know it's not working. Okay, even though breastfeeding promotion, so I've got 3 more minutes left. Even though breastfeeding promotion I showed you earlier is not a very cheap intervention, and here's another figure that suggests the cost per dali is 1,750, it clearly still does save a lot of lives. It gives you lots of benefit in preventing morbidity, and so it remains one that would remain on my shopping list of best buys in South Africa. Here's one that we've talked about at this conference as well, but I don't have a sense has moved very much, and that's therapeutic feeding. One of the arguments is that it costs about 2,000 rand to rehabilitate a child with SEM. Again, if you look at the cost per dali at $200, it's easily comes into the arena of highly cost-effective interventions. Okay, now moving on just beyond, what about technologies? And one that would stand out would be something like CPAP. Now, I'm not giving you the numbers here, but again, taking technologies, modifying. In Malawi, they use bubble CPAP, but they've been able to prevent respiratory distress in newborns at a high level. Again, I'm not giving you the numbers, but if one looks at the cost per dali of an intervention like this, it comes through as being highly cost-effective. We've had a fortification program in South Africa for a long time. We've actually haven't been able to show the benefits of that. And there's a number of reasons we know for that, including whether the products actually do have the micronutrients in them. But in Bangladesh, just by supplementing with sprinkles, every time the child eats food, a few sprinkles, that intervention, again, comes through as being highly cost-effective. And it's certainly one I would put in my shopping bag as wanting to consider in South Africa seriously. We've had IMCI since 1998. Many of us think IMCI is long dead. I don't believe so. I think the investment in IMCI still needs to continue, that the training of staff needs to continue. And while we don't have great examples of success in South Africa, certainly some of examples from other countries like Nepal, particularly the incorporation of the neonatal component, suggests that it's worth continuing to spend money on IMCI. And if you look at the numbers, of course, cost benefit, cost effectiveness, you'll see again, from a cost utility perspective, the cost per dali is very low. And then finally, 2 issues which we're going to cover because my time is now almost up, is we're going to cover in the second session is the whole value of AI and how AI can change the whole dynamics. And so, for example, in the area of diagnostics, you've now got these portable ultrasounds, or POCUS as we call them. You can have X-rays analyzed by AI. And even I was talking about jaundice earlier, these days you can have a cell phone, take a scan of the baby's skin, send it through, and you can get a bilirubin result within 5 minutes just by the use of technology and AI. So I think that's going to make a big difference. At the moment, it's on the expensive side, but I have no reason to believe it won't become cheap very quickly, and we'll hear more about it in the last session. And finally, data utilization. And again, I think you'll hear about that more in the second session. But we've got lots of data. It sits there, it collects dust. Let's bring AI in. It can take this information, change it, and I could give you examples of how it's been able to identify malnutrition hotspots, what have you. It could work out where you can predict where our next measles outbreak is going to be, or where malaria is a problem. So this is two interesting areas. And my number 10 in my bag is, I'm saying, what would you add also into the bag? Let's place one more intervention. Perhaps you want to suggest what you want it to be. And so just my final slide is that we all want to ensure the patient's best interest, but you can't get away with the fact that you have to ration care. There's always be resource allocation, and it's very difficult. I work in the neonatal space. People say, but this baby needs it. But I'm saying sometimes, but another baby needs something else more. And it's a difficult moral dilemma. But hopefully this brief discussion, I've given you some kind of an economic framework to decide, how do you decide what might be a best buy? And I think as a country, we should be focusing on these best health buys. And a lot of them, we've got them already. We need to optimize their delivery rather than always wanting to get the latest fad or gadget. So thank you very much for that opportunity to offer some insights about economic analysis and what might be possible best buys. Okay, so the bad news for me is that there's no time for questions because I've used up my full quota of 15 minutes plus 5 minutes for questions. So if there are questions, we'll have it in the panel discussion that we've got 10 minutes at the end. But at this stage, I'm going to ask that Dr. Ruder prepares her presentation, and let me tell you a little bit about Dr. Ruder. Okay, so Dr. Tanya Ruder is a community pediatrician at WITS. She's an executive member of the South African Pediatric Association. She's been a key person in the background in past child health priorities conferences. So whether it's this one and previous online sessions, or whether it's been the live sessions, the last one we held in Johannesburg, she's often what I would call the conference managing director. She makes sure that everything runs smoothly. But today we're going to listen to her presentation on innovative approaches to cost-effective pediatric and childcare globally. So, Tanya, please go ahead.
Thanks, Dr. Just trying to find this presentation. Can you confirm for me that you're able to see it?
Yes, we can see it. That's fine. Your sound is not the greatest. If you can just get a little bit closer. Thank you.
Okay, let's do it. Through this, and hopefully that's a little bit better. Okay, so I think this is, for me, this is a very exciting opportunity. I love innovation and thinking differently about things, and so the opportunity to explore this as a topic was quite exciting. So when we speak about innovation, it's identified by the UNICEF Office of Innovation as a key enabler for driving transformational change in children, right? And so it's hardly an option in the way that I think about it. We have to move, we have to progress, and we have to think about things differently if we actually want to see the achievement of the goals that we're aiming towards. The same office, the UNICEF Office of Innovation, speaks about these transdisciplinary, collaborative, innovative nodes, right? So lots of big words, and they don't use the word multidisciplinary or interdisciplinary. It's transdisciplinary, which actually means that they're actually coming together and creating something completely new, rather than continued work in silos. And so they work in this sort of framework where they have the things that we know, the things that we know we don't know, the things that we completely don't know that we don't know, and then what we know. And if you just summarize this quickly, or like what this actually means and what you need to do with it, is to, in this quadrant over here, strengthen and apply existing knowledge, and up here we need to explore the areas that we know we need a little bit more work on, right? Up in the bottom corner, we need to capture the hidden insights. So sometimes things are happening, we're not really sure that they're actually going on. We don't know that we know this, but things are kind of working and we haven't really quantified it. So capture what's actually going on in those sorts of spaces, and then prepare to adapt when we actually don't anticipate things that either might be working or not be working. So just things that are unforeseen and perhaps out of paradigm. So why I would argue that we need to embrace innovation, that it needs to be part of our practice. And the question is why? So obviously all of these reasons listed over there on the side, but at the end of the day, if we, Amina said it earlier on, we're all trying to get to the same place. We all want to see universal quality care for children. And like this river that you can see in the picture over here, it's moving towards the ocean. If this water is not moving, if it's not on its way to the ocean, it's stagnating, and we know what happens to stagnant water. So we want to be moving, we want to be generating better data, we want to be doing cost-saving initiatives and improving our efficiency. It can all be done, and all of that can be done with innovation. So perhaps captured very nicely by Henry Ford. So if I'd asked what the public what they wanted, they would have said a faster horse. We really know that something completely different out of paradigm was really what they were looking for, or we didn't know that we needed, right? So from now, that was a little bit of background theory, and I want to spend a little bit of time now just discussing the things that we know, like innovations that are actually currently in place, and we're going to get things that we're very familiar with, and then go to the things that perhaps we don't know as much about or haven't really explored and can consider implementing in our practice. So one thing that wasn't commonplace but has become something that we more and more is point of care diagnostics. Prof spoke about a couple of these things already, including the point of care. So things like testing. You shouldn't do a rapid, you should do an ELISA, but we also know that HIV PCRs are available at point of care, HIV viral loads are available at point of care, TB resistance testing is available at point of care, and all of these things help to just improve efficiencies, cost saving, time saving, improve diagnostics, improve the appropriateness of management. It feeds into the antimicrobial resistance agenda if we do things correctly. And so just if we're thinking about it, we're using innovations every single day, and we need to embrace them when they come. And then, as mentioned, it doesn't always have to be complicated. It doesn't always have to be expensive. Prof spoke about this, about the bilirubin interventions that are available. Let's speak about this one over here, the bilirubin. And the point is that often we can see that babies are a little bit yellow, but that inter-user variability and the judgment call that we make is not often accurate. And the simple device that's calibrated to when you actually need to worry and when you don't improves inter-user reliability, has a good sensitivity, good specificity, good positive ratio, and really it's simple and available, right? So when we know for some reason our bilirubinometers, the transcutaneous to function, a simple little ruler like this can actually work quite efficiently. And then the mobile sensor technology that we hear, so we're very familiar with this in our watches and in our smartphones, and sometimes rings, all sorts of things to be used for common conditions to get an almost immediate response to what is the bilirubin and whether action needs to be taken. Similar interventions related to the treatment. So do we need to have children on continuous phototherapy? And again, innovation, if we hadn't what we know to be true, we would never know that we could phototherapy, and just about questioning how we think and how we and the are available. Again, something that should be there and somewhere in our frame of reference, telemedicine, right? So the historical model, GPs once upon a time used to go to people's homes. I'm not sure that that's common anymore, but the idea of patients not necessarily accessing the health facility, but still getting a quality of care through virtual platforms or telemedicine is being in a variety of places, including at Barra. So the Barra Ped Surgery Department have actually implemented a telephonic follow-up service for their minor procedures, and now even because they've had such success for their more complex patients as well, they found that it's acceptable to the patients. It's obviously cost effective. They don't have to come in, get their files, all those sorts of things, and they have found that it's actually been a safe intervention that they've implemented. If there are any concerns that the patients raise when when the consultation is done telephonically, they're offered the opportunity to send via WhatsApp if there's a that's looking a bit funny or whatever it is, or obviously they're told that they must return if that's necessary, right? And then they've developed a system now where also they're doing a pre-operative assessment, recognizing that patients often come from primary care facilities or different. It's often 2 or 3 consultations before the actual surgery is booked. And so saving the patient some time, sharing educational material that helps them manage in an interim period. So all of these sorts of innovations just to save time and allow the specialist services to function at where they're complex cases. Okay, Prof's already spoken about this. So frugal, we don't need to always spend a lot of money. There are simple solutions that can be put in place when we don't have lots of resources. You don't always need the heavy technical equipment. So an example, and I've spoken about earlier as well, bubble CPAP. Doesn't have to be all the big fancy stuff. You can do it quite simply with the things that you have. And obviously a similar example is the Coke bottle as a spacer. Another kind of intervention that we can offer is, and we've done this already, task shifting, task sharing. So historically, we've thought this is a doctor's job, this is a nurse's job, this can be done by an enrollment, whatever it is, right? But recognizing that with appropriate training, appropriate supervision and mentoring, we can actually task shift and tasks to different levels of care and take, as the GPs historically, take the services to the people and where they require it. So in many settings, so community health workers are treatment of common conditions in the community. Nurse practitioners trained in case management. I mean, I'm not using the word IMCI, but that's quite an effective innovation, where we sort of, and recognizing that there's a compromise. There's always going to be a compromise of accuracy for the simplicity that we require, but it is cost effective. And I think the key thing, ensure that all of these things are actually sustainable, effective, and able to provide quality of care, is making sure that there's a risk. Okay, now getting into things that perhaps we're less familiar with, but also make significant pros. And one of the key things about innovation is that these things need to be acceptable locally, applied in various settings or adaptable to various settings, but also scalable. So there's this thing called the good things, where projects that are interventions that are available on usually smartphones, so iPhone or various smartphone-friendly versions of interactive games using humor and things that engage with particularly young people where they're at, and reliable information. So this one particularly addresses misinformation around vaccine, gamified, available in various languages, and relatively to scale. Other interventions often on the same platform, so that is tied to, so there were a couple of comments earlier about climate change. We know that this Internet of Good Things platform, data free as well, offers interventions on all these more using. So, and the point here is that it uses existing technologies, existing of this way for education. We need to this wall and these things that's now passed, because these.
Right. I'm not sure if it's me or it's Tanya that's.
Yeah, we've lost Tanya's back.
Sorry. Oh my heaven.
Okay. The reception was a bit poor for the last minute, Tanya. Maybe you can just start again. So
okay. Is this slide, Prof, or shall I go back?
Why don't you continue from here?
Okay, so sorry about that. Okay, so I was speaking about the various digital platforms that we have available that are now being taken to scale and offering reliable information in a way that's really accessible, so gamified and chat-based and accessible to the youth. This one is not data free, but it's a very lay data. You can kind of see that there's it's a WhatsApp sort of base. And again, just providing reliable information about climate change, gender-based violence, taking it, or all of these things, taking it to the national level, the community level, and the education that we know is actually required in a way that is accessible. Let's move on, because we're out of time. Okay. There's a concept, and this is the last one I'll speak about. There's a concept called digital public goods, which, so it was quite an interesting, I read the definition of it, and it says open source software, open data, open AI models, open standards, open content, everything is open to privacy and applicable laws, best practices, do no harm, and this is key, help to attain the SDGs. So making sure that the vision is aligned to the achievement of goals. And I didn't quite understand that, and so I had to ask ChatGPT to explain it like I was in high school. And it said, essentially, the digital public goods are things that are what used to be things like libraries and parks. So publicly available for free, it's beneficial generally to the community, and really achievement of a variety of goals. So the particular health-related goals are things, often things like the District Health Information System 2, which is used by a national government and a variety of NGOs in the South African space. But one of the interesting interventions that's also different app, a variety of them, but one particular for MNCH, that just offers, it's an app platform which independently is very difficult and expensive to develop, but it's also fully customizable to the setting. So it involves various levels, and it involves various workflows. You can see the household, the community health workers, the supervisors, and the program managers all involved, and accessing this at various levels of care. They log in at various levels and register of the family members. So all sorts of things have been considered, and it all links to each other. They have a variety of workflows. So community health worker goes into the community and encounters a pregnant patient. They fill in the form, and then multiple triggers are activated, and you just continue through the flow. So this customer, so the basic information. So many of the speakers said that this information is all available. The packages, the interventions, the guidelines, it's all there. But to actually customize it to the setting and make sure that it's locally applicable, all of that is possible. So the base product is available, and it just needs to be customized, and it's free, and it's leveraging off existing technologies. Okay, so I've spoken about a couple of things, and then just a little proviso: is innovation always good? And obviously, no, there's always risks. And then there was just this that said that innovations within the global food system have contributed to the current state that we're in, triple burden of malnutrition, hunger, micronutrient deficiencies, overeating. But also, I think the point here, the confounding point here, is that perhaps the value system of the food system is not aligned to health. But this point, just to make sure that we don't recognize that everything it's always rosy. It's not about always implementing. I think this idea of reasoning backwards, so when we're innovating and thinking about doing things in a new and different way, start at the end point saying, what do we want to achieve? And again, we all want to be those rivers reaching the ocean. We all want to achieve universal quality healthcare for children. And what do we need for this to be true? What do we need for this to come about? So this framework helps you to think about it. It helps to identify blind spots. It helps to identify obstacles not known about. And so it's just, and the point is that it's actually used I think generally in a marketing. And one of the key things about that is that it's taking us out of that siloed approach to fix health. and just thinking about that transdisciplinary innovation that I was speaking about in the beginning. So placing interactions in an integrated system where social purpose is unified. So we have to continuously evolve, adapt our practice. And then it's all of those sorts of things over there: action-oriented, future-focused, participatory, holistic, systemic. Purposive, transcends individuals and disciplines and practices, and actually creates something new at the end of it. Okay, so why innovation in pediatric healthcare? I think it's important. I've already made that point, and I say it, but also recognizing that not everybody is an innovator. It actually is skilled work. We have those people who always want to try things, and as leaders and managers, I think to some extent that has to be fostered. To an extent, we have to be open to new ideas, open to change, open to learning from mistakes, because it's often to be willing to explore and trust the process, and then just know that sometimes it's going to be uncomfortable. That point of not just working in ourselves, this is not a health problem only, we need to work across the board, so be collaborative, consider solutions that are completely relaxed. At the end of the day, to achieve all of this, we need a value system that's aligned, single and consistent effort in working to achieve that. Okay, and that's me. Thanks very much.
So thank you very much for that, Tanya. You've just made it on time. We won't have time for the questions, but I can see lots of applauses. I think you've taken us on a wonderful quick trip to what are the kind of things available out there, what's the great stuff that we can get, hopefully mostly for free. You've talked about what are some of the considerations as we think about innovations. And I think also you've asked us to reflect on what our goals are. So I think, again, a great presentation. We will move on. Just to say there's been lots of submissions on the Q&A. There's discussions happening out there. I appreciate that, and please continue that. Besides what's being said by the presenters, we can have a side conversation. I can't respond to all the issues because I'm trying to be a chair as well, but I've been reading some of the comments, and I think we're having a good side discussion. And I'm sure, Tanya, your contribution will also elicit its own discussion. All right, but you can see both Tanya and I were talking quite fast because we were trying to get in the maximum bang for our bucks, trying to be as time efficient as we could be, maybe a little bit too fast. But we're going to move on immediately now to our third speaker, and then we'll have about 10 minutes for questions. Our third speaker then is, again, someone who's probably well known to most of us. It's Dr. Shuaib Kauchali. He's a community pediatrician and now head of the WITS division of community pediatrics. He's taken the position that I've just vacated. He served in various roles at district level, at provincial level, and national health department. And I think it's probably not inappropriate to call him South Africa's SAM guru, referring, of course, to the management of severe acute malnutrition. Because if you want to know something about SAM, Shuaib's your man. But today he'll be addressing us on managing limited resources without compromising quality. Shuaib, the floor is yours.
Thank you very much, everybody, and thank you for this opportunity as well. When Haroon contacted me, he said, "I'm giving you a topic which I think you will do justice to, and I don't know if I will, but I will do my best." It's a double-pronged question: managing limited resources without compromising quality. And Dave asked me to say this. So Dave, I have nothing to declare. And to the priorities. But I also want to take this opportunity to say that thank you for the Division of Community Pediatrics for welcoming me so nicely and warmly and inducting me to the process of rethinking about how to get a straight line. And so thank you for that. So what is this presentation about? So I'm going to speak a lot around health systems and care systems and the complexities in which we actually play and we navigate through. And hopefully by the time that I've finished, we would have come up with a mental picture of the methodology that is usually used to solve complex problems as the one that is presented to us today. I mean, you have limited resources, you want to protect children, you want to keep them safe, and you want to give them good, effective, high quality, and efficiently. How do you go about doing that? And that's the philosophy that is enshrined in the value-based systems, making the most with the least that we have. And it's not just South Africa that is grappling with this, and it's new to us because we've transitioned from a nothing that fits all to something that we are trying to fit for all in terms of the NHI bill as NHI Act, as Haroon had mentioned. But I'm hoping that for the newcomers into this field of child health and systems thinking, that I would entice them, encourage them to start thinking in terms of the management sciences and also utilize some of the toolkits that are available for the improvement sciences. I will definitely not talk about the value-based system in detail. I'm not going to have a conversation around the universal healthcare debate, or even pretend that I'm a health economist on financing, costing, and budgeting. I will use those words, but I may not express them in detail. So let's unpack this problem. So the key here for me is managing, right? Limited resources is a constraint. Limit and resources is it's an input parameter for problem solving. And then there is another valency that says don't compromise quality, but achieve quality or retain quality or maintain quality if you have to use a positive valence. And then have a better outcome, which is called quality of healthcare for children. And for me, I think when we talk children, I think we all implicitly mean the rest of the families and the communities in which the child grows. So a tongue-in-cheek comment. So what is this management mean? Is it an art or is it a science? So Schroeder and Schroeder put together a very nice approach, which is holistic and has a transformative agenda to success and organizational change that is brought about through a combination of art and science. And you can read what they speak about that. I try to create a cartoon example of what South Africa is about today. It is an art, it is a science. So I borrowed that from Schroeder and Schroeder. But there is this other cell or circle that keeps impinging and encroaching between the art and the science elements of it, even though the art element, and I'm not sure if you can all identify what this, I won't give you the answer, but the art and science actually work very well in solving very complex problems, because science is a hard science. Art is the nuance of taking the science into action and contextualizing it to the problems that we want to solve. There's something that interferes with this process, and you can see the arrows I'm trying to show that as that question mark circle goes into the art and science and takes over that, we get nothing, no results actually. So the art of this is actually playing in the center, is to understand and appreciate the art, the science, and this question mark that I'm holding on to for you to answer towards the end, and let's see if you can get that answer right. So I'll pause here for like 10 seconds and give you an opportunity to look at this and let me know, what is this person, what is the problem that this person is trying to solve? And I'm going to read the text around him. It does not matter how many resources you have. If you do not know how to use them, it will never be enough. This is something that came to our attention a decade ago, when we were conceiving the idea. Amina mentioned this earlier this morning in the project that has now been completed. But what is the problem that this person is trying to solve? So if you look at this here, you'll see that there are various components of a science that is there. So this person is standing on a bunch of ladders. His objective, his goal is to cross the wall, right? But he's got all the ladders that he needs to actually achieve that. But because he doesn't know how to, he doesn't know how to use it, he will keep asking for more ladders to go up and cross the wall. So the answer lies in understanding what processes need to be put in place within this system that expects him to actually cross the wall. And you can see from there, and I'll try to unpack these processes as we go along. And I'll leave that second question with you, is what is the problem that this person is trying to solve? And I can expect some of the answers as well. So going back and standing on the shoulders of giants that have actually done improvement science work for decades, and in fact, close to a century now. I call this of snakes and ladders. We tend to fall, we climb up the ladder, we slip down the ladder, and we tend not to understand the problem well. And he describes this as, if you can't describe what you're doing as a process, you don't know what you're doing. And I like this because every time that we are encountered with a problem, we are short-staffed, we don't have lights, we don't have water, there's no drugs, supply chain is broken, etc. Our leadership is sleeping on the job, etc. So those comments do come out because they highlight the elements that contribute to making that process a successful one to give us the results. He also goes on to say that 85% of the reasons for failure for deficiencies in the systems and processes are deficiencies in systems and processes rather than the employee. The role of management is to change the process rather than badgering the individual to do better. Stephen Covey takes this a step further, and he gives us the ladder example, the analogy again. And in all of us, we have management and leadership qualities. And we have to ask ourselves, where do we belong and what are we really doing? So management is efficiency in climbing the ladder of success. But leadership determines whether the ladder is leaning against the right wall. And I think we have to choose the battles that we can fight. We need to know what ladders to use and how to use those ladders and make sure that people who are climbing the ladder are supported to get to the other side of the wall. So we developed a framework, and this is, again, the Donabedian model adaptation. And we classified this in a way that would allow us as child health practitioners, maternal and child health practitioners, to apply science of improvement through the lens of the input, process, output, and outcome lens or model or framework. And we called it the square, circle, and the triangle. So you might have seen this previously, and if it hasn't sunk in then let me just go through it very quickly. On the left-hand side is the square box. This box is really literally square, and it's got further squares in it. These are elements that are components that are necessary but not sufficient in giving us the result that we would like to see, and which are effective and efficient healthcare systems and our survive and thrive targets that we are pursuing. That has to pass through two filters. The first filter is the service delivery platform. In this case, is the district health system, which is based on the principles of primary health care. And it has to also look at patient's journey along the continuum from prevention to treatment to rehab and back into health. But the key in transforming or changing what the inputs are able to deliver to become outputs, active outputs, are actually in that circle. Number one is governance of the delivery of quality and access in the catchment area. That's the population that we deal with. Implementing clinical protocols safely and reliably, and providing respectful care for patients and supporting them with information and counseling. So there are three elements there. There's a systems element, which is governance and leadership. Second one is the people, the beneficiaries that we are trying to reach, and then there are providers. And I heard earlier today about burnout and what's happening. So we get this gruntled or frustrated if the box does not operate with the circle, and we don't get any results. Dr. Wakua tried to simplify that and said that perhaps we should show it in an angle with a way that we would like to cross the bridge. And in order to cross the bridge, we need these inputs. But we cannot cross the bridge if there is no bridge. So to build that bridge, build meaning the doing action, the processes are necessary. So the inputs are necessary, processes are necessary, that put together creates a sufficient system to get the results that we want to see. And Deming then reminds us again, this is many 50, 60 years ago, that meeting specifications is not enough. And what am I talking about? Ideal clinic, national core standards, supply chain audits, HR vacancy rates, data systems. These on themselves are of no value unless they are passed through the milling process that allows us to interpret the context in which these poor quality is being delivered. And obviously on the input side is one of the keywords called limited resources. So where are we going to maximize this from? And then I like this one here because it's an adaptation of Deming, Berwick, and Batalden, all improvements scientists that work together. So imagine yourself now working in your back environment, and you are asking this question, why are things not getting any better? And the reason for this is in the science of improvement, we have to first accept, and that acceptance comes in by articulating this phrase. All organizations are perfectly designed to get the results they are now getting. If we want a different result, we must change the way we do things. Change the way we do things comes here in this part here, in the processes that we are going to be working with. So the healthcare system, very hospice-centric, very heavy on the load on cost on the hospital-based case management, and then we tend to lose, the what's known as the upstream factors that contribute to illness and wellness, and less budgets are spent in that particular area. This interaction between budgetary allocation to a system and the way the system is designed gives us a dilemma on how well we are going to actually perform to get the best outcomes with minimum resources. Right now in South Africa, we're going through an austerity measure. And guess where the austerity measure is going to have the greatest impact? Because we have voices in hospitals, patients die, it goes into the media, we get to see that those type of services are also, are actually given priority. Yet the priority through the evidence-based science says should be at the base and not at the apex. So some practical ideas. So I took all of that and I put it together in terms of something that we can go home with. I'm not going to read through this. I'm just going to explain that leadership in governance is very important. And this requires an accountable and a transparent governance system, right? Management systems at the district, hospital-based systems, primary healthcare, community engagement, and household and families. Everybody has a role to play in creating the efficient linkages between each other to create the best result. But then, anybody else done this? It sounds like we all know what needs to be done. Yes, well, Rwanda did it, Ghana did it, Ethiopia did it. You mentioned Nepal, Haroon. Uganda is doing it, and Mexico is doing it. So, and they've had tangible results by using low-cost, high-impact interventions. So why is it that we are struggling to get there? So there's a new beast that's coming across into South Africa, and this beast is actually 10 years old when they described it. We are a bit late in adopting, and as usual, we tend to take things very slowly. So one of the key messages here is the evidence, the science, and the action that needs to be done needs to be aligned. And if it's not aligned, we are going to be remaining behind with time. So let's just unpack what this value-based healthcare system shows. So it had a number of things that they mentioned, but I think I pulled out 3 that are pertinent to us, and Tanya's covered some of this. Haroon covered a little bit of that as well. But for me, building and enabling IT infrastructure, I think this will solve a number of problems, and many speakers this morning also mentioned this. Obviously, geographical access is important. Technology will help. Ghana is using drones to deliver drugs to people's homes, and I think there's creativity and innovation in that. It is low cost, high impact, which reduces cost on the individual, but takes the cost on the taxpayer. And for me, in a universal health coverage, that may be helpful. But lo and behold, what do we like? We like a tout brute. We want to kill Julius all the time. I don't understand. So these are 2 programs that are going to be launched and have been launched in the last month. And you will see them coming downstream, and we will see how they will have. Our job is to make sure we take what works for us and improve it. But we've also asked this question in the past: is why is there a lack of action on the ground? And this particular cartoon example tries to show that between cost and delegation of power on the columns, the current state of affairs shows us that we are in a state of paralysis. That's because we are not making any decisions at the institutional level. For example, a tap is not working in the neonatal ICU. Now, if the tap is not working in the neonatal ICU, should we escalate this matter to the provincial and national and the minister's level, or should the hospital be able to solve that? You know, so this is the kind of thinking that we've gone through. The paralysis is because there is a lot of draconian and bureaucratic systems in place that are not patient-centric or population-centric. And what we would like to see is an ideal situation on the right-hand side that creates an agility and agency to make the change. So what can we do on the front line? I think I'm going to leave this slide here. I think the message is very clear. When you take bloods from a patient, ask yourself, is that test important? When you do an X-ray, ask yourself if that is important. Coming back to our question, there's not really a magic bullet here. So let's see how many of us actually know what the problem this person is trying to solve. Anybody can answer. I just have 1 minute left. No, it's not trying to cross the wall. The problem is he does not understand that he's got resources that he must rearrange, redesign, reorganize so that the processes are streamlined so that he can cross the wall. Should we be throwing another ladder at him? Is that what he's expecting? So when we are in our wards, in our systems, district health systems, and we say we are short-staffed, which is very true, I'm not denying that, we should also be asking what are we doing with the existing resources that we have? Should we be throwing another ladder at the problem? And the answer is obviously no. So we will end off with this one here. Accountability and systems thinking. Data drives knowledge and gives rise to power. Play in the center smartly and stand by your ethical and legal duty as advocates. Optimize processes. Yes, it can be done. If you want to know more, ask me how. And then there's a call to action here for you. Know the laws, know your rights and responsibilities. It is open access. This is not a secret. You need to know how to fight politics with politics. And here's the last quote. The individual has been crushed by our style of management today. To change everything, we have to work with management to get it right. And why? Because we have the data that drives knowledge, that gives rise to power. And as simple as that, there's no cost attached to it. We are all endowed with that process. With permission from you, if we have time, we can play the video.
Go ahead, Shuaib.
Okay, thank you.
It looks like we don't have sound, so you're going to have a go at trying to get the sound going again.
Okay, let's do that. I see a lot of questions in the. No, I'm not getting it.
Do you have any idea what we might do differently this time? Because when we were pre-planning, it worked.
Share a link to the talk in the chat. If it's not working.
I can. Yeah, I could do that at the end. But what it's showing? Let me just while we are at it, I just wanted to share with you. So the WHO has worked towards, we've seen patient-centeredness, hospice-centricness, and so on, and then finally recognize that patients don't fall from the sky. They don't drop as patients from the sky. They actually originate, the disease process originates from the homes and the communities that they live in. And they will have to live with this condition for the rest of their lives if it's a long-term illness condition. So how do you change our mindset from individual patient-centered care, which is nothing wrong with it, to population-based or people-centered care? And this 2-minute video actually summarizes it quite well and introduces concepts that I've just gone through on how to create efficiencies and reducing waste and collaborating with all partners that actually work towards the people-centered care and giving everybody a voice in getting the system right. I'm going to pause there and stop. Thanks. Sorry, I went over time.
No, it's actually a miracle to get Dr. Kauchali to be exactly on time is very difficult. So I'm actually very impressed. You've done well. So Dr. Kauchali is obviously a thinker and a philosopher. And so the problem with that is that he presents very challenging presentations to us. And when you're giving Shuaib a talk, you're going to get boxes and circles and arrows. But the point of all of that is he forces us to think, and he makes these very uncomfortable presentations, because now you have to say, what's he saying? Of course, what he's saying is true. What do I do about it? And then he brings real world examples into it. And then you say, yeah, actually it's there. But he does offer a lot of reflection and clearly leaves us at the end of a presentation like this with more questions than when you started. You think you're going to get all the answers, and then Shuaib gives increases your burden by making you think even about more questions that you have to answer. But Shuaib, again, fantastic. I know we only gave you 20 minutes and then we could easily have made this a 40-minute talk. But I think from the applause you're getting, it's great. Okay, so we're running a little bit behind time. We've probably got about 4 minutes to answer questions. So let me see Tanya, if you can unmute yourself and put on your video. And at this stage, I'm happy that there are a number of questions and comments in the chat, but I'm happy for people who want to ask a question. Just go ahead and unmute yourself and let's get real live questions. So does anyone want to raise questions for either Shuaib, Tanya, or myself? Please just go ahead. We've got about...
Sorry, there's a question here. Can I take that question? Don't forget the question mark in the circle. What was the question mark in the circle? Let's see who answers that one. Please unmute. It's called the big elephant in the room and nobody wants to talk about it. Right. So what I'm trying to get to is that this is not unique to South Africa. We have a concept of political interference with science and art. And if you looked at Schroeder and Schroeder's model, navigating political science is actually included in the art of interacting with science. I created a third one because there is no art to this and there's no science to this, right? It's an external, extraneous factor that's impermeating within the science and actually destroying very good science work that is currently going on alleviating poverty, reducing the burden of disease, and improving health outcomes and development of children. There is no question about that. Now, does the Constitution allow for that? Yes. Does the legal system allow for that? Yes. So why are we sitting on our laurels and not activating the system to hold them to account? That is the question mark that I'm talking about. So while it says it's an interference, I like to look at it as a solution. And the solution is, let's play the game in the center. Let's all come. Let's talk.
All right. So, Dave, I think it's a great point and a great position to perhaps end this first session. I think all two, maybe even all three speakers have raised a lot of issues. And hopefully there'll be opportunity as we go on to some of the subsequent presentations to reflect back on these presentations and say, what have we learned? But I'm very aware of time, and our next two guests are ready to present to us. We were scheduled to start at 15:10. So Shuaib, thank you very much. Tanya, fantastic. Thank you very much too. And let's move on then to our next question. You can carry on asking questions in the chat, and Shuaib or Tanya, if you've got time, please go ahead and answer the Q&A questions. But for now, we're going to move on to the next bit of our presentation. And as in this session, we shift our focus again to the role of technology and artificial intelligence in optimizing healthcare. And so we'll be hearing from two national and international experts on how we leverage these tools to provide cost-effective care. And I'm hoping, again, we'll have 10 minutes for a short panel discussion. So our first speaker is Professor Ntobeko Ntusi. Professor Ntusi is the president and CEO of the South African Medical Research Council. I think a lot of us knew Glenda Gray because she was a pediatrician, but Professor Ntusi has been the new president and CEO since July this year. He's had many positions, but he was the previous chair and head of the Department of Medicine at UCT. And among other things, Professor Ntusi is committed to advancing medical research, particularly in his new position, but also innovation. And he's passionate about improving healthcare outcomes, which is the focus of our conference. And so it was a great pleasure and a delight for me when he accepted our invitation to come and address us today. He does have leadership which spans various national, regional, international platforms. I won't go through his whole CV, but it's a great pleasure, Professor Ntusi, to invite you to address us and to address us on leveraging technology for optimal health. So thank you very much. And I see you've already put up your presentation, so please go ahead. And I trust you've got your video available. It would be nice to have a look at you if you are able to get your video operational. Thank you very much, Professor Ntusi. Please go ahead.
No, thank you so much. It's an absolute delight to be part of your meeting and to contribute in a small way. And I am grateful to you and Dave Leroux for the invitation. So I will share some reflections on how we can leverage technology to optimize healthcare delivery. But in starting my presentation, I would like to start by showing this history statement from the South African Medical Research Council, where we acknowledge our complicity in the health disparities and inequities in this country and commit ourselves to the continued promotion of justice and dignity in health. So these are my disclosures that I'd like you to note, and none of which have any relevance for today's lecture. So before we think about technology and the applications of technology to healthcare, we need to understand what the problems that need to be solved by this technology are. So in revisiting what the trends in global health, you will note that in the last 3 decades, there's been significant advances in scientific knowledge. And alongside this, we've witnessed a massive explosion in the costs related to healthcare. Alongside this, we've witnessed a globalization in clinical trials, obviously a good thing, a decolonization in global health, another good thing. And we've also witnessed a number of new therapeutic areas, in particular immunotherapies and gene therapy, but also the advent of digital health and artificial intelligence, which provides a value proposition throughout the entire spectrum of health, all the way from screening and diagnostics to risk stratification, prognostication, and understanding outcomes. And alongside these important advances, there are a number of really important and concerning challenges. These include widening health disparities, not just between the global north and global south, but even between countries in the global south. In a country like ours, a clear urban, peri-urban, and rural gradient. We also see a crisis of governance in healthcare present in every country without exception. An epidemic of non-communicable diseases, challenges with mental health, healthcare worker burnout, but also receiving trust, not just in governments, but in science and macroeconomic issues that impact negatively on how healthcare is experienced all around the world. And what are the major technological advances in 2024 that are aligned with the global health trends I've just described? So we've seen a substantial rise in the application of generative AI, an increase in the use of virtual hospitals and telemedicine, the application of digital twins in the diagnostic process and planning of therapies, the use of virtual and augmented reality in different healthcare delivery aspects, particularly in theater. Again, an appreciation of the role of prevention and a number of important advances in preventive healthcare. The application of 3D printing, precision of personalized medicine, particularly in the domains of oncology and immunotherapies, and of course, a convergence of physical care with mental health care. What about the pediatric and adolescent landscape? You will see again similar technological advances related to the use of AI, telemonitoring, diagnosis, the use of mobile apps, and customized pediatric electronic health records. Significant advances in infant ventilators that cause less trauma, and of course, gene therapy, amongst others. And if you look at the year 2023, there have been significant trends in health technology and over 1,000 new startups. And you can see the 10 areas that they largely focus on, aligned with the trends I've just described. And in fact, artificial intelligence is at the top of that. And so we need to ask ourselves, in the pediatric setting, how can we think about the application of these tools as tools that enable us to solve challenges of equity, challenges of access, affordability, and ultimately improvement in outcomes. And so when one looks at life satisfaction amongst children, in this bar on the y-axis, you note increasing scores, and the higher scores denote lower satisfaction. And in the x-axis, you will note different time periods. And what this demonstrates is that children become increasingly less happy as they grow older. And what we have noticed in the last decade has been a differentiation between the levels of life satisfaction between girl children and boy children, but also quite striking geographical variations in the level of satisfaction of children. Outcomes can definitely be improved, and you will see that in the year 2022, almost 1 in 30 children died before their 5th birthday, and 1 in 60 newborns died. 1 in 50 children between the ages of 1 and 60 months died, and 1 in 60 children who died were aged 5 to 24 years. But this is an encouraging slide showing that when you look at the last 4 decades, the number of children less than 5 years who have been dying has been getting progressively smaller, from 115 million 4 decades ago, and in the last decade down to 15 million. And the area of the world where we've seen the biggest reductions in under 5 mortality, neonatal mortality, and 1 to 16 month mortality has been in Southern Asia, and the experience in Sub-Saharan Africa has been checkered. And so if you look to see where most children are likely to die, Sub-Saharan Africa lights up, and it still accounts for about 80% of the childhood mortality. And what are the drivers of mortality in younger children? These relate in the main to prematurity, lower respiratory tract infections, birth asphyxia and trauma, as well as infections, including malaria. And what policies do we have in place to ensure that every birth and death is registered and recorded? So about 98% of countries have a mechanism for birth registration, but concerningly, only about 80% have a mechanism for neonatal birth registration. And even more concerningly, only about 60% have a mechanism for stillbirth registration. And if you look at the under 5 mortality rate by SDG region, you will see that Sub-Saharan Africa lags substantially behind other parts of the world. And if one looks at obesity as a measure of complexity in childhood illness, which impacts significantly on outcomes, you will see that between 1975 and 2016, where blue and green is good and orange and red is bad, there's been a significant rise in the amount of childhood obesity, both in boys and girls. And this is particularly marked in high-income countries, but South Africa has high levels of obesity amongst boys, but particularly high amongst girls. And one can see what the trends are over time in overweight and obesity have been in different parts of the world. And you'll see the concerning trajectory of obesity in sub-Saharan Africa. So how can we leverage technology then to achieve the kind of impact we want to see? And really one has to think of it as transforming healthcare to create a system that is fit not only for the challenges it faces now, but also for those it will face in the future, which requires both cooperation and strategic partnerships. So how are these partnerships to be constructed, and what characterizes those that enable the achievement of equity? A number of important characteristics we've described, which include trust, the style of communication, acknowledging inequalities, obviously equitable distribution of funding, capacity building, and other characteristics that I list on the slide. Importantly, the World Economic Forum has described equity as the foundational goal for all change if we are to see the kind of improvements in health and healthcare that we envisage. And the achievement of equity is premised on 4 key pillars. 1, equitable access and outcomes, healthcare system transformation, technology and innovation, and of course, achieving environmental sustainability. So what is the role of clinician scientists like you in achieving these laudable aims? So we need to create and generate new knowledge and apply existing knowledge in new ways, and to do so collaboratively. And I've described the kinds of partnerships that enhance the achievement of equity, but also to innovate and to pioneer scholarships that allows us to be able to make important advances. And to do so by establishing an enabling culture for future generations. And so in this review of important goals and activity, a technology must be seen as an enabling, not as an end on its own. In the science of the future, to achieve maximum impact needs to be characterized by its responsibility, its relevance, its responsiveness, and its resilience. So, ladies and gentlemen, I've shown you that global health research and clinical care is in a state of evolution with ever emerging important priorities. I've also shown you some important global trends in child and adolescent health, which demonstrate that sub-Saharan Africa carries a substantial burden of morbidity and mortality. And I've described that technology must improve healthcare efficiency, affordability, and access. And clinician scientists like yourselves have a critically important role to play in driving improvements in healthcare. I thank you for your attention, and I'll be happy to take questions that you have.
So thank you very much, Professor Ntusi. That was a great presentation. I think you've highlighted the major technological advances globally for us. And I think you've also outlined the changes required for this technology to be more available more equitably. Also appreciate the fact that you've taken the time to look at some of those pediatrics and the statistics, sharing them with us and highlighting how what are the areas that technology has to address to significantly influence child health outcomes. And clearly, we hope that the MRC will continue to have this interest in maternal and child health and promote those efforts. So I'm happy to, we're going to have a session at the end, if you are still able to stay, but we can take a few questions now. So I'm happy if anyone wants to unmute themselves and ask a question. But while you're thinking about it, perhaps I've got a question to start us off. And it's the issue of that technology seems to be advancing inexorably. And it's the role of South Africa within that sphere. Are we mainly going to be users, or do you think we have a role as to be developers? And clearly, the MRC as a research establishment, how do you see that role playing out? What should be our role as persons engaging with technology? Mostly as users, can we be developers, or what balance between the two?
Thanks, Haroon. So I think we need to be doing both. We obviously are major consumers of technology, but in order to respond optimally to the challenges of the day and the fundamental challenges in our context, we also need context-specific and local solutions. So what does the SAMRC do? We do 7 things, right? We run a large intramural program that does the kind of research that cannot be done in universities. And then secondly, we fund individual researchers at universities, but also establish centers of excellence there. We run a very large capacity development program for the country where we fund up to 12,000 masters and doctoral students annually, as well as having a customized program of support from postdocs, early and mid-career and senior interns. We administer and manage grants. We spend a lot of time communicating science to affirm the value of science in society. And a lot of the work that we do is underpinned by the partnerships we build. But most critically, to respond to your question, the 7th pillar of our work is that we support innovation in health. And in fact, the South African Medical Research Council hosts the Health Innovation Platform for South Africa. And at any one stage, we have between 60 and 100 innovation programs that we fund. And these span the entire value chain from diagnostic tools to applications for information, to equipment for therapy, new drugs, and tools for prognostication. And so we help clever scientists who have ideas. They come to us for funding. We work with them to develop those ideas into prototypes. And then we help them to take those prototypes from the potential they have to entry into the market, and also help them to have startups. And so there is a platform that we host for the country called Medic, which I would encourage anybody with ideas to look up and see how their ideas can be funded through that. We also collaborate closely with TIA, the Technology Innovation Agency, the Department of Science and Innovation, and assist people at different stages of product development to bring those to the market. And the goal is really to do what you're asking, to see how we can assist as many South African innovators take the idea to the market to achieve optimal impact. Thanks.
Thank you. So, in fact, Dave has got a question which is on the same kind of theme. But Dave, do you want to unmute yourself and ask the question? I think it's a great question. Should I read it?
No, just a concern that early adopters tend to be well empowered and use technology and become more empowered at the expense of slow adopters who are disenfranchised, so that technology and new tech deepens inequity instead of narrowing it.
And your question is, how can we use tech to decrease inequity?
If that's possible.
Yeah. So I suppose, again, another tough question, Professor Ntusi, but it's the issue of, so we recognize that we want to reduce inequity. Can you see tech successfully doing that? I think we heard a little bit of that in your talk, but perhaps you want to follow that theme a bit further.
Yeah, so I think it's a very, very difficult question, Dave. And it's something I would discuss very regularly. I attended and spoke at the UN General Assembly in September of this year. And that was one of the major themes about how AI specifically may be used to try to reduce rather than widen disparities. And there are no easy solutions. I think governments need to work collaboratively with civil society, with academia, with industry to really improve the socioeconomic standing of individuals and communities. And I don't think that this is a solution that lies in a single sector. It will take a multi-sectoral approach with a whole of government and whole of society approach. But I don't think there are easy ways of doing it. And the challenge is not just in our corner of the world. If you look at North America and the US, they are working with the same challenges with ever-widening disparities, despite even more available technology in their context. And so no easy solutions.
Great. Well, thank you very much, Professor Ntusi. It was lovely to hear from you, and we look forward to perhaps hearing from you in future conferences as well. As I said, we've been able to ask a few questions. If you're able to stay on, that would be great. There may be opportunity further. If you need to leave, okay, fantastic. Thank you. All right, so we're not at the end. We've got one more great presenter. So let me introduce our next speaker, and that's Professor Bruce Basset. Again, a very distinguished individual. He's got the title of Distinguished Professor of Computer Science at Wits University, but he's also a Professor of Applied Mathematics at UCT. And he's, among other roles, he's the founder and director of Africa Data Science Intensive Program. So clearly spans lots of arenas. He spends his time between Joburg and Cape Town because both universities want him. And I think with all the exciting developments in AI, artificial intelligence, Prof. Basset must have one of the best jobs currently available. I mean, every day brings new exciting developments and opportunities. And he obviously gets to play, and I'm using the word play in a fun way. He gets to play with these things. I know it's not all child's play, but he gets to play with these things every day. And so he's going to address us on whether artificial intelligence can assist us in providing more effective healthcare. Bruce, thank you very much for joining us today. Delighted. And please go ahead.
Brilliant. Thanks, Haroon. Hopefully you can hear me. I'm going to assume you can. If not, wave. Yeah, I'm actually at a conference on AI safety, how to stop the AI from taking over the world. So it's really nice to talk a bit more down to earth. But I should start by saying that I really know nothing. I'm not a medical person at all, although we started some amazing projects, mostly at Wits. But that's a really important caveat. I don't know anything about medicine, and my only pediatric knowledge is a memory of a very traumatic night that I spent in hospital when I was about 5. So I'm going to be coming at it very much from the AI side. But I think that's really exciting because I think for so long, for hundreds of years, actually, we've had this very siloed mentality essentially forced on us because it takes 10 years to become a specialist in one area, and who's going to go and spend another 10 years becoming an expert in another. And I think there's incredible opportunities that AI is going to leverage. The mere fact that I'm here chatting to you is an indication, I think, of how things are changing, and I think it's wonderful. This siloing has huge costs that we are mostly blind to, and we only now and again get an insight into it. And there's one that's famous in mathematics. In 1994, a paper was published in a journal called Diabetes Care called A Mathematical Model for Determination of Total Area Under Glucose and Metabolic Curves. And the idea was quite simple. You take a curve and you break it up into little rectangles and triangles. You want to know what is the area under the curve. And this paper currently has 567 citations, but it was a complete reinvention of a method that was actually discovered in the Babylonian era more than 2,000 years ago. But so it's a beautiful example of silos, right? You know, this knowledge that was developed by mathematicians more than 2,000 years ago had not diffused into diabetic care. Now, I'm not saying that mathematicians are much better than medical people, because you definitely wouldn't want mathematicians looking after ill children, that's for sure. But I think it's a lovely reflection of what is being missed currently. And there's this thing, you don't know what you're missing, right? And so all of us go around going, yeah, it's fine. And it's only when we start to share that we realize what's possible. So I'm really excited about the opportunities. So I stole this, I took a screenshot from Sadhana's talk earlier. She was talking about risk stratification for children. Here's what we would have called an old expert system, decision tree. And presumably this was the result of many experts sitting to build a flow chart of making decisions. So one way to frame the whole AI thing is to say, how could we learn to this flow chart automatically without needing experts, but just using data? And that's what machine learning in many ways is. How do you learn automatically from data without needing experts? The second thing is you could say, well, here the experts identified a few decision points, a few key things. What if you wanted a lot more variables? For sure, there will be a lot more variables that you could take into account, but the flowchart would be very complicated. And that, again, is part of what AI is about. It's how do we do it automatically, and how do we do it as well as possible? So I'm going to just, I don't know how many of you have experience in AI. I'm just going to show you a little bit about how artificial neural networks, which is the basis of AI, work. So like imagine that you have an image and you want to characterize what image, which digit is it? So here, this is clearly a 9, but it's not a neat 9, it's handwritten. So the way neural networks work is that you have these very large networks, and the information from the pixels flows through the network and ends up highlighting one of the digits, in this case, the digit 0. You can see this one is selected, but the number of connections is very large. And currently, the big AI systems have trillions of these parameters. So if you compare the slide on the previous talk, there were maybe 10 or 15 decision points. Now the AIs that we are building have trillions of parameters, which are all learned automatically from the data. And of course, if you've got trillions of parameters, you need a lot of data, but that's what digitization has enabled. One of the cool things that has happened is that we've seen incredible progress. This was 2 years ago, where I asked an AI image generation called Midjourney to give an image of an international female lawyer. That was the prompt. That was 2022. This was a year later, 2023, and a year later in 2024. So you can see this amazing progress. We can now do more than just generate images. We can generate video. So here's a prompt. A man and a woman in their 20s are dining in a futuristic restaurant materialized out of nanotech and ferrofluids. So the important thing is there are no such restaurants made out of ferrofluids and nanotech. So this is not just regurgitating something that it's seen. And this is from OpenAI Sora. Let's see. So you can see things like the reflection on the table. It's really learning about physics. You can see the natural gestures, and you can see that it's sort of contextualized how to put these two people inside something that looks like a ferrofluid. And ferrofluids are usually tiny, very small. So very impressive. So, you know, there's this incredible advancement in AI. Another one, if any of you have ChatGPT, I hope you all have played with ChatGPT. I did an example. I did a search online for bad handwriting, doctor handwriting. I don't think this is particularly bad, but I just uploaded this into ChatGPT and said, what does it say? And it said that this was the transcription. I have no idea if this is correct or not. But then I asked it, okay, but what's the context of this image? And it said, oh, the context is the patient has been identified as having pancreatic cyst, et cetera, et cetera. So we really are, I think, moving into an era where we can digitize, for example, handwritten medical documents quite easily, with some errors, but perhaps the question is it good enough? Because we still have hallucinations. Although the systems are improving rapidly, there's always the chance that it makes a mistake. And so we always need to be checking, especially when it comes to patient care, of course. One of the big factors in AI is this running towards artificial general intelligence. And I think it was Dave raising the thing about the tech bros. Silicon Valley is all in on trying to build artificial general intelligence and an AGI, as it's called, generally it would be a sort of a system that could learn to do anything that humans can do. So rather than building a specific AI to do a specific task, you would have a general AI that could learn to do anything in much the way that humans can. And of course, this is going to have huge economic implications. And it's been driven or it's partly driven by and leading to an incredible investment in computing. We have seen in the last 7 years a 7 million-fold increase in computing power for AI. At the same time, the cost of that 7 million increase it's only been a 200x improvement. But now we're running into the situation where all the major players are buying access to nuclear power stations because the electrical burden is so high, but very, very rapidly evolving field. And it's a massive multinational arms race where universities can't compete, which is problematic. Anyway, that's all the kind of high-level context. I'd like to do some examples that I found. So I found some interesting this one in New England Journal of Medicine, a recent review. And here what they did is that they asked, can GPT-4, how does it compare to, in this case, 849 practicing physicians who were tested against the Israeli board residency exams? And what they found is that there was a strong variation by discipline. So for general surgery, GPT-4 was better than 44% of the practicing physicians, pediatrics only 17%, psychiatry 75%. So that's an interesting thing. We're seeing that the performance of these models depends very much on the discipline. And of course, the interesting question is, if you did this in the South African context, how much would this drop? And we have a program to test that. But yeah, it would be really interesting. I would find it very interesting to know what is it about gynecology and pediatrics that's giving the AI so much trouble. Here are those data kind of broken out. On the x-axis, you see the percentile. So here we have a small peak at 50%. That means that model, they ran the model 120 times with different starting conditions. That's why you get this distribution of scores. The dotted line or the dash line in each case is the passing score, the score you would have needed as a human to pass. And so, for example, general surgery, all 120 examples would have passed and been roughly in the middle of the pack. For psychiatry, they're all in the top 25%. But then again, for pediatrics, they are passing. They would all have passed, but they would be down at the bottom of the cohort, which is kind of interesting. Here was a specific example I found related to pediatrics, where they were using AI to diagnose. What was interesting is that they used a smartphone connected to the device that they were using to record the videos, and they took the data over 5 years. So that illustrates, I think, a couple of things. One is, we can do this with kind of off-the-shelf technology, but that it also takes time to build up the data. Haroon, sorry, how much time do I have, just to make sure, because I know we don't want to go. Have I got 2 minutes? Is that
That's your 15 minutes, and you got another 5 minutes after that. So you've got a good 7 minutes at least.
Perfect, brilliant. I thought, one of the things with the rise of these models is that they kind of universal, right? So everybody can use them. And that means that we need to be very precise about their failings and successes. So, it's really important that we quantify the statistical performance very well. So, for example, in the previous one that I mentioned, they quoted the sensitivity and specificity of 93% roughly. I thought I would just very briefly, I don't know if everyone's familiar with sensitivity and specificity, but I thought I would just go through it. So imagine that you have an algorithm to predict whether an image is a cat or a dog. Over here, we have the true label of an image. So let's say we've got 100 images. We've got the true label of the photo. Here we have the prediction. So if the prediction was a cat and the true label was a cat, you add 1 to this cell in this matrix. If the algorithm predicted it was a dog, but it was actually a cat, of course, you add 1 over here, and that's bad. And then vice versa. If the true was a dog, but the algorithm predicted it was a cat, you add 1 to here and otherwise. So, of course, in medicine, this is typically, did you get the right diagnosis? Yes or no? Do you claim that the patient has cancer? Yes or no? So it's these kind of binary outcomes. And then sensitivity is you take the number here. So if you had 100 images, you would split the 100 over these 4 cells. If there were 50 cats and 50 dogs and the algorithm were perfect, you would have 50 over here, 50 over here, and then 0 in these. But of course, in general, there will be some errors. So the sensitivity is this number divided by the sum of these 2 numbers, this plus this. In other words, the number that you correctly identified as cat divided by the true number of cats. So that's the sensitivity. And then specificity is the same, but for the other row, the number that you incorrectly, actually, I've just realized that I may have made a mistake here. But yeah, so I think it might have been rather vertically, the number that you correctly identified as dog divided by, the sum. I should have moved it across. Anyway, the idea is that you have these 4 numbers and you're interested in the ratios. So one thing that I do want to just make, because I've noticed that it's not always appreciated, is sensitivity and specificity are not enough to fully characterize your algorithm. Because one way to think of it is that you have 4 numbers here. You know that the 4 numbers added together must be the number of samples you have, So that means you have 3 independent quantities. So sensitivity and specificity give you 2, but you need another one. It's just really important to remember that sensitivity and specificity is not enough to fully characterize your performance. I think in the medical literature, I've noted that people often just give those 2. Like in this example, in this abstract, they just give you the 2. You still have room to do really well or really badly. Anyway, okay, that's enough of a statistics lecture, but it is just maybe a broader point that we are moving into a very quantitative phase so that we can control these AIs and kind of hunt for biases. Because any bias, if everyone is being exposed to it, obviously that magnifies the thing. Whereas a specific doctor might be biased, but maybe they only see 1,000 patients in a year or 100 patients. The bias in some sense is limited. But if you've got an AI system that's seeing millions of people, a small bias could add up very quickly. Okay, so how can AI help? Now I'm going to speculate. More or less nothing that I'm going to say is specific to pediatrics, but it is general to medicine, and in fact, general to many other fields as well. Of course, with diagnosis and screening, optimizing treatment plans, we actually have a grant just recently on managing antimicrobial resistance with AI, reducing hospital readmissions, optimizing resource allocation. This is something that take a lot, and every Amazon do a lot on. So a lot of those algorithms can be just ported across very efficiently. Improving administrative efficiency. So the doctors that I know love this app called Heidi Health. It's mostly used in private practice, but you can just dictate your notes instead of having to take them. Transcribes, it gives you summaries. People love it. And it's free for limited use. You might want to try it out. Cost-effective telemedicine solutions, drug administration adherence. And then at the population level, we heard a little bit earlier, really nice talk about the optimization of health at the population level. And then support for mental health. If you haven't played, I might try and do it, a demo with the paid version of ChatGPT. You can ask it to act like a therapist, and it does a really good job. We saw how well it did in psychiatry, but it's very good with supporting mental health as well. So I think that's a really interesting application. Anyway, I'm going to finish up now. If you haven't seen the documentary AlphaGo, it's on YouTube. I highly, highly recommend it. I've watched it 4 or 5 times. It's incredibly poignant, but it really, I think, highlights the tsunami that's coming and the kind of human aspects of it. It's a wonderful, wonderful documentary. I highly recommend it. And if you're interested or feeling overwhelmed by this AI, you haven't understood anything I've said, maybe you're just like, oh, it seems impossible, I recommend using ChatGPT or WhatsApp. You may not know that in WhatsApp, when you go to the search bar, it's got AI there. You can ask it questions. You can ask it to generate images, and just ask it to act as a tutor for you. And if in the worst case, you can just say, explain it to me like I'm 5, and it will then explain it very simply. And then the last thing I'll say is GPT-5 is coming at the end of this year or early next year, we expect. And GPT-5 is supposed to be 100 times bigger than GPT-4, which means that its quality should be significantly better than GPT-4. So definitely we're living in interesting times. I'm going to wrap up there. Thank you so much.
So thank you very much for that, Bruce. I think you brought the excitement of AI to all of us. I must say, I've been thinking about the issue of, so why did ChatGPT do so badly in pediatrics? And I must admit, I haven't found the answers. I hope when I punch it into ChatGPT after your session, it might give me the answer. But I think thoroughly enjoyed that talk, and I'm happy for now for the participants to perhaps raise any issues. I can see you getting some applause coming through. We've got still about 5 minutes. I think we had some good questions to Professor Ntusi, so I'm happy to direct the questions to to Bruce. But if you want to raise any more questions for Professor Ntusi, you're welcome as well. But let's perhaps give Professor Basset 5 minutes. Who'd like to ask any questions? All you wanted to know about AI and were too frightened to ask. You can do that now. So there's an answer from a pediatrician that it's all we are artists, we are not scientists. Or rather, we both, but we're more artists than we are scientists. What do you say to that, Bruce?
Well, I would be curious. I mean, it would be really interesting to have you look at that Israeli board examination and see how they encode the art in the questions. But maybe it's a lot of subtle judgment. It would be very interesting. I mean, the fact that it got passing scores, so it would have, if it were a human, it would have been passed. But something about it there. So maybe it is those nuanced subtleties.
Okay, but the truth is it's getting better and better. And I'm sure if you repeated that same study today, it would beat us poor pediatricians by a much greater margin. So Shuaib, you've got your hand up. Please go ahead.
The others had their hands up before me.
Oh,
let them go
I can
first.
only see your hand. I can't see any others. Who?
Got her hand.
Jenny's hand is up.
Ah, Jenny. Okay, I can't see it, unfortunately. But Jenny, please go ahead.
Thanks very much. Can you hear me, everyone?
Yes.
Excellent. Thanks very much for some very interesting presentations. I'm a family physician in the Eastern Cape, and I'm not very tech or IT savvy. But my question really is around the education, both undergrad and postgrad. Now, I understand you're not educating medical people, but just a general principle. Now we can punch anything into ChatGPT. We can get, well, you've demonstrated how to read a prescription right through to what is something. Do we need to change the way that we teach to teach people to be more discerning, or do we need to teach people sort of processes more than actual information? So I don't need to teach someone what is a liver abscess or pancreatic cyst because they can look that up, or they can just put it into their AI. But do I need to teach them something else now, or reading AI?
Absolutely. Great question. And so I think around the whole issue of AI, there's a lot of disagreement between experts. So I would say nobody knows the right answer to many of these questions, and how it's going to impact university. I think it's going to have a huge impact. Like, for example, with maybe I can just try a demo, and you should never do a live demo, but I'm going to just talk to ChatGPT. Hi there.
Hey there, how's it going?
Good, thanks. Could you act as a pediatrician for now?
Sure, I can take on that role. How can I assist you today as a pediatrician?
Well, actually, I don't know much about pediatrics. Could you guide me through the basics, but as an expert?
Absolutely. Pediatrics is the branch of medicine that deals with the medical care of infants, children, and...
No, I don't want summaries. Can you give me an example of a pediatric case that would be really tricky? And can you put it in the context of South Africa, please? And could you use a South African accent?
All right, let's dive into a complex pediatric case then. Imagine a young child in a rural area of South Africa presenting with chronic cough, weight loss, and night sweats. This could be a tricky case because these symptoms are common in tuberculosis.
Okay, I think you get the idea. So I think for training of medical students, you could ask it. What's nice is you could say, pretend to be a patient with a certain disorder, and then you ask the medical student to ask questions, and then you say, okay, now evaluate the medical student. So I think just the short answer is I think we're going to see a huge change. I will just say, you mentioned that maybe we can consider not teaching the more factual stuff. I think there's a good example from Britain 20 odd years ago, when calculators became very common, they decided not to teach children the times table. Because they said, why do they don't need it? It's times. And it was a complete disaster, partly because it's true you can just use a calculator, but somehow internalizing and learning the times table was critical building blocks for higher order cognitive function. So that is the real concern. Are we going to make the same mistake so that we are actually making humans, futures graduates stupid? We just don't know. With GPT-5, it may have an IQ of 140. It raises all sorts of questions. If we can all just have an assistant with an IQ of 140, what is anything anymore? Yeah, it's easy to lose context, but yeah, we can have long debates about this.
So Bruce, let me just come in. So Jenny, at Wits, we're taking AI very seriously. And so I think I recognize that a device is all you need now as a doctor. I'm not sure what happens when you lose your internet connection in Oliver Tambo district. But we've actually, Bruce and I and others have got a randomized controlled trial going right now. We've got some funding from the Gates Foundation, where we're actually going to allow final year medical students going into their PEDS or their medicine final exam. They're going to have a case for 30 minutes, and then they're going to have to present it to the consultant for 15 minutes. But during the time they're with the patient, they're actually allowing them to use a cell phone with ChatGPT. And the randomized control trial is, are they going to perform better or worse? I think it's an open question because, of course, the key element is the examination. And at the moment, I don't think ChatGPT can find that spleen or can hear that murmur for you. It may do that very soon. But certainly in history taking, differential diagnosis, and even investigations, it can be a great help. The only problem here is they're going to have 30 minutes. So can you, in that 30 minutes, effectively use it? And your question was, where does this mean in terms of education? And for me, the key is learning how to use ChatGPT. That's what we're going to train the participants in the study. And I think that's the future. Because if this study shows that the students with ChatGPT are doing better, we're committed to allowing students to use ChatGPT in the exams. Why not use a tool like that if it clearly improves your performance in the clinical setting? So exciting arena, Jenny. And again, Bruce is part of the study that we're doing. Shuaib, I think I can't see any other hands, so please go ahead, Shuaib.
Thanks. So Bruce, thank you very much. I mean, this is really fascinating and mind blowing, as they say. But the potential is really in harnessing the strength of the individual person, that's the human, and getting the automation done by a machine. But my question really is not about that. That's the appreciation part of it. I think that's where 80% of AI work is going to rely on. The 20% where the cerebral thinking, the lateral thinking, the innovation, the creative thinking is highly dependent on how much data has been fed to the LLM models, the large language models, because it uses a Bayesian logic to say that given that I have this and this, these are the potential outcomes that I'm going to be seeing. And then chooses one of them. Sometimes you don't like it, and then you'll have to hone in and apply a restriction to it. And exactly just the way you demonstrated. Now you were not happy with the first response, and then you stopped it and you went more specific to get it. So the question really is, how much of our autonomy as humans are we relinquishing to decision making to an artificial model who doesn't have the fingers, the ears, the eyes, as Haroon was saying, to assess what the true facts are in reality.
Great point. And Shuaib, I love the fact that you quoted Edward Deming so much, because there's really great stuff there. Because in the end, leadership is as important now as it ever was. A leader who's negative or positive, who has vision, makes a huge difference. I will say, maybe I'll just share my screen quickly. This is from the new O1 model from OpenAI, which is specifically designed to think deeply. And you can see this is on a competition math, so these are hard problems. GPT-4 only got 13%, whereas O1 was up at 83%. And then on PhD level science questions, O1 is actually significantly better than human experts. So, you know, I think it's worth thinking of imagining that within a year or two, we will have AI that on any logical reasoning task are better than the best experts. And then the question is, you know, what is the role of the human in this context? And I think obviously in the role of, in the context of pediatrics, is that human connection. But you know, I will also say they're making incredible progress on humanoid robots. So I would be, you know, in first world countries, I think within 5 to 7 years, we'll see robots running around doing a lot of the toil work in hospitals, I would imagine. I think it's a pretty obvious. I did want to say something else. I really did, but I can't remember. Getting old. So I don't know if I actually answered your question, Shuaib. Sorry.
Yeah, no, it's just the ethics of using AI. You know, it comes always to the forefront because we cannot replace. I remember my previous boss used to say, you cannot outsource your thinking.
Well, exactly. And that's the danger, right? I have a friend who uses ChatGPT for everything. He said he feels like his brain is idling. So we shouldn't, but I think for a lot of people, we're going to. I will just point to a study that came out that they were testing physicians, again, on some board thing. The physicians scored 74%. Physicians plus ChatGPT scored 76%, but GPT alone scored 90%. So we're getting into this interesting situation where if the human and the AI disagree, we really have to think hard about who's actually right. So, but the ethics is such an important question because we also don't want all of our health systems being controlled by America and they can just flick the switch and say, you know what, I think we're going to switch off the access to ChatGPT, which I think in the era of China and etc. is a really non-trivial. If these systems keep getting better and better, at a certain point they will be national security risks. So we have to avoid that sovereignty risk as well as address all the ethical issues that you raise. They're only going to get more important, I think, and more pressing.
Thanks, Bruce.
Thanks.
Professor Ntusi, thank you very much for staying on. I'm not sure if you want to reflect on any of the conversation we've had related to AI. You don't have to, but I'd welcome any comments if you do have any.
I mean, first I can make one comment. You know, there's a lot of people dabbling in AI in the clinical sciences, particularly in the diagnostic space. And the danger is that, you know, both the testing and validation sets often come from the global north, and are often single-center institutions, not generalizable, particularly to populations in sub-Saharan Africa. And so one finds that the diagnostic performance of many AI models now certainly is very poor. And what we need is to have a lot of studies that led in South Africa, tested in South African populations, validated in South African populations for us to be able to optimize the power of AI in the diagnostic space. We think that's a really important message. You can't just export platforms and expect them to perform the same way that they have in other contexts.
Thanks. And in fact, that's the other study that Bruce and I are taking on. So we're actually going to be taking 500 patients from Bera and subjecting them to 5 different LLMs, including ChatGPT, and also then subjecting 500 ECGs, X-rays, CAT scans to the same kind of process for exactly the reason you say, to see firstly that, and Bruce can comment, to see firstly how it performs, but more importantly, to train it to start being more appropriate for the South African setting. Bruce, you want to comment very briefly on that?
Yeah, absolutely. I think it's a critical thing to test. I mean, for example, when I asked it, ChatGPT to speak with a South African accent, it gave, I think, a very stereotyped, example. So you can ask it, you can say, oh, you're a medical doctor in South Africa, and it will try to hallucinate from the little that it knows about what the conditions will be like. And so I think you're exactly right. We have to test this very carefully.
Okay, well, thank you very much, everybody. We've reached 16:12. Thank you for those who stayed on, but particularly thank you to Professor Basset and Professor Ntusi for their presentations. And I previously thanked Dr. Kauchali and Dr. Ruder for their contributions as well. I think it's been a fantastic afternoon. We've learned so much about so many different things. And so appreciate, as I said, everyone's our guest speakers, but also I appreciate everyone for raising some very pertinent points. The conference continues tomorrow at 10 o'clock, so we'll see everybody then. But for now, bye-bye to everybody.